Hello, everyone. My name is Dr. Bethany Niell. I'm the Section Chief of Breast Imaging at the H. Lee Moffitt Cancer Center in warm and sunny Tampa, Florida. I'm delighted that I was invited to talk with you today about a topic that's near and dear to my own heart. My great love is making sure that patients have access to high-quality breast cancer screening, and that includes high-quality screening when you're pregnant and lactating, or if you're high risk or average risk, or if you're intermediate risk, or if you're a man, or if you're transgender. However you identify yourself, I want to make sure that we get you access to high-quality breast cancer screening. My topic today will be screening for breast cancer during and after pregnancy. I do have conflicts of interest I wish to disclose to you. I do receive grant funding from the National Institute of Health and the National Cancer Institute. I have my own R01 and I am a site PI for a multi-center R01 with colleagues across the country. I have an equipment loan agreement for research only with Hologic. I have received honoraria for providing grand rounds and resident lectures at the University of Wisconsin and have received travel funds from the ECOG Akron Radiomics Working Group. Lastly, I hold a number of chair positions with the American College of Radiology, including a panel chair for the appropriateness criteria. And I'll be showing you some of those appropriateness criteria later in this presentation because we have one devoted entirely to how we want to take care of women who are pregnant and lactating. The first thing I want to do before I move forward is make sure that all of us are on the same page with terms. So I am a subspecialized breast radiologist. A breast radiologist is a doctor who interprets mammograms, we interpret breast ultrasound and breast MRI, and we also perform image-guided procedures, and that includes breast biopsies. These are biopsies that are done in our office. Biopsies done in the operating room are done by a breast surgeon. I'm a breast radiologist, not a breast surgeon. A mammography technologist is the specialized technologist who acquires mammogram images. I have some incredibly talented mammography technologists at Moffitt Cancer Center with whom I'm very fortunate to work. But as a breast radiologist, I'm the one interpreting the images, not acquiring them. I want to also make sure that all of us understand that there are different types of mammograms. So when I think about mammograms, I put them into two different buckets. Bucket one is a screening mammogram, and bucket two is a diagnostic mammogram. So a screening mammogram is done in women, usually women. It can be done in men, but it's uncommon. Screening mammograms are done in patients who have no symptoms. You have no lumps or bumps, you don't have any pain, you're feeling normal, you don't have any recent abnormal imaging that would require additional dedicated mammogram views. Usually, a prescription is not required for a screening mammogram. A diagnostic mammogram, that's what I called bucket two earlier, that is performed in a number of situations, but a diagnostic mammogram is done in a totally different way than a screening mammogram. So when you come in for a screening mammogram, you come in, you change, you have your images acquired, the mammography technologist acquires your images, and then you head home without the images being reviewed real time by the breast radiologist like me. A diagnostic mammogram is different. For a diagnostic mammogram, you come in, you change, your mammography technologist takes images, and then you sit in the waiting room while the images are reviewed real time by the breast radiologist. If more images are then needed, or if we have to do additional testing, like a very focused ultrasound examination, then we would do that at the same time. It's important for all of you to understand those differences because the workflow is different, but also because the indications for the exam are different. So for a diagnostic mammogram, if you have a lump or bump or you feel pain, then you should be coming in for a diagnostic mammogram. If the breast radiologist saw something on your screening mammogram, we want you to come back for more imaging, then in that situation, you would also need to have a diagnostic mammogram for the additional views. If you had an abnormal finding on a breast MRI or a CAT scan, or you've had a prior finding that required follow-up imaging, all of those are indications for a diagnostic mammogram. The difference is also important because it's usually the case that a prescription from your referring healthcare provider is required for a diagnostic mammogram. I should have mentioned on the mammogram slide one other component, and that is when I'm talking about mammography throughout my presentation today, I'm using digital mammography and digital breast tomosynthesis in the same way, but the exams are not quite identical. So digital breast tomosynthesis, you might have heard it called DBT. You might also have heard it called a 3D mammogram. It's not really a 3D mammogram, but that's sometimes the term that's used. A DBT exam is a special type of mammogram, and it presents the breast radiologist with slices of mammogram images acquired from the mammogram machine. And digital breast tomosynthesis, or the so-called 3D mammogram, tends to allow the breast radiologist, when reviewing the images, to find more cancers compared to digital mammography. And it also frequently allows us to recall you fewer times for things that are not cancers. I'd like now to take a minute and talk about screening mammography recommendations. This is important for us to cover because there are so many different recommendations that it generates a lot of confusion, I think. Frankly, it generates confusion not just for patients, it generates confusion for doctors too. Because if we're talking about different guidelines and we aren't agreeing on our guidelines, what actually is happening is that we're not getting our patients in for mammography as often as we need to. So in the United States, unfortunately, today we have about 3 to 4 out of every 10 women who are not getting their mammograms as frequently as they should be. And that's really a shame. So what I want to do is take a minute and just talk about some of the differences in the screening mammography guidelines that apply to women who are average risk. So the different guidelines in general have various recommendations for whether or not you should be getting mammography beginning at age 40, 45, or 50. And the guidelines differ about whether or not you should get a mammogram every year or every other year. The guidelines also differ on how long you should get screening mammograms if you are average risk. What I want for everyone who's listening to me today to understand is that what we all want to do is understand that, one, all of these medical professional organizations agree that screening mammograms save lives. So we are not debating that screening mammograms allow us to detect those breast cancers earlier, and when detected earlier, patients have better outcomes. So there's no debate there. The debate lies only in when to start screening, how often to get screening, and when to stop. The more often you get screened, including at an earlier age, the better chance you give me and other breast radiologists to find your cancers earlier. The important part, as I mentioned, though, is that because of the confusion around screening mammography guidelines, what's happened is that we aren't getting as many patients in for regular screening mammograms. In addition, we've done research investigating how often patients know whether they are or are not at average risk. So I would imagine that if I took a poll of my audience today, that I would actually have few patients in the audience who have had a formal discussion with their doctor about their breast cancer risk factors. And when we ask the general population, we find that only about 1 in 10 report understanding their level of risk. As a result, what happens is patients who are at an elevated risk, they're at higher than average risk, those patients don't know that they need more intensive screening regimens. So the guidelines that I have on your screen, as I mentioned, are for women who are at average risk. How then do we manage patients who are at elevated risk? Well, patients who are at elevated risk need more intensive screening regimens. So there are a whole host of articles that and online websites that you can go to look at the various breast cancer screening recommendations. This is one of them for women who are at average risk, and this is from the American College of Radiology guideline. This was just updated in 2021. The two bullet points that I have there for you are just a tiny subset of the topics within this guideline, but the important part for us to take away is that we need patients to know their risk factors by age 30. Why? Because if we don't investigate our risk factors until after that time, our patients who are at elevated risk do not have the opportunity to benefit from getting screening at earlier ages or from more intensive screening. So as a result, it's really important. If you have not had a conversation with your doctor about your risk factors, please put that on your to-do list for the next time you have an appointment with your healthcare provider. We want all patients to have a risk assessment performed by age 30. The American College of Radiology and the Society of Breast Imaging recommend a screening mammogram each year beginning at age 40 if you're at average risk. But what happens if you're not at average risk? What if you have an elevated risk or a higher than average risk? The American College of Radiology also has guidelines on this topic, and you can see that citation on the slide on your screen. For patients who are at higher than average risk, we would recommend that you have more intensive screening done often at an earlier age. So it depends on why it is that you're at elevated or higher than average risk. So the devil really is in the details, as we say. But as a general guideline, patients who are at higher than average risk should be getting mammography each year, sometimes beginning as early as age 30, certainly no later than age 40. Some high-risk women also benefit from having a breast MRI performed in addition to a mammogram. And for that, some patients who are high risk need a breast MRI to be done as early as age 25. Again, we recommend risk assessment by age 30 because we want patients to understand their risk so you have the option to benefit from these more intensive screening regimens. I have breast MRI on the screen beginning as early as age 25. We generally will recommend MRI be performed in addition to mammography, but there are some exceptions. Because we do not generally perform mammography before age 30, again, there are always exceptions. You can imagine then that if you are at extremely high risk, there are occasions in which you would be getting a breast MRI each year starting at age 25, and then at age 30, you'd begin your breast MRI every year with your screening mammogram every year. The American College of Radiology and the Society of Breast Imaging are by no means the only medical professional organizations that have screening guidelines, and I want to be thoughtful and inclusive about other medical professional organizations. ACOG is one of them. I have just a couple of their guidelines up on the screen for you, and ACOG has guidelines on how to manage women based on risk and how to do imaging during pregnancy and lactation. So please feel free to check out those guidelines and online resources as well. The National Comprehensive Cancer Network also has guidelines that can be found online for you. And their recommendations for breast cancer screening during pregnancy are up on the screen right now. What I want for you to understand is that during pregnancy and during lactation, what we want to do is get as close as we can to the screening recommendations that are appropriate for you based upon your level of risk. So as a result, what you can see on the screen right now is that our recommendations for imaging during pregnancy, for example, this does not include women who are lactating or breastfeeding on the screen. So during pregnancy, what we want to make sure we do is continue mammography. In general, we do not perform ultrasound as a sole screening recommendation. Breast MRI requires contrast administration. And in general, the contrast administration for a breast MRI would not be performed during pregnancy. I'm going to talk more about that in a minute. I mentioned earlier that one of the commitments that I do that's near and dear to my heart is making sure that the American College of Radiology appropriateness criteria are up to date. And I serve currently as the panel chair, and I have a wonderful group of breast radiologists across the country who help us to make evidence-based guidelines, and they come from all sorts of practices and many states across the country, and these breast radiologists are donating their time to help us with these evidence-based guidelines. So there are a number of appropriateness criteria guidelines that are available, and you can actually check them out at the ACR website. We also have patient and family-centered documents that include language to make sure that everyone's able to understand our recommendations. The one that I'm going to spend some time talking about today is the one that is breast imaging in pregnant and lactating women. Before I move on to have that conversation, I want to again make sure that all of us are on the same page. We talked earlier about the different types of mammograms, but I want to remind you that mammography uses X-rays. That being said, the radiation dose is very low for mammography. So the radiation doses that you tend to hear about on the news, for example, are usually radiation doses from CAT scans or sometimes nuclear medicine scans. And in general, those X-ray doses, those radiation doses, are higher than what we use for mammography. Mammography does have some limitations. The mammograms are limited by dense breast tissue. So I have a mammogram that's up on my slide right now. And what you can see actually is that the gray portion is fat. So the gray portion, for example, closer to the skin surface is fat. The light gray portions are breast tissue. The bright white triangle towards the right-hand side of your screen is actually part of the muscle that's on the chest wall that we get on a mammogram. And you can see at the very far right side of the mammogram image, you can see a bright white mass. And that is that patient's tiny little cancer that's pretty far back in the breast tissue. Would have been exceptionally difficult for that small mass to have been palpated or felt by the patient or her doctor. This is exactly the role for mammography. We want mammograms to find breast cancers when they are small, because when we find them small, our patients have better outcomes. You can see on my mammogram image that because this patient's breast tissue is not dense, that it's actually pretty easy to see that small little cancer. Imagine, though, if there was a lot more of brighter white breast tissue overlapping that mass. It would be tougher for the radiologist to see the breast cancer through the dense breast tissue. Women who are pregnant and women who are lactating tend to have denser breast tissue. This is why you often hear people say the sensitivity of mammography is lower when you're pregnant or lactating. It simply means that it is more difficult for the breast radiologist to detect the cancer because of the overlapping denser breast tissue. This is why the breast radiologist will ask that if you are lactating, you feed your baby or you pump right before your mammogram image, because it can help to decrease that dense breast tissue just a little bit to help us out. Remember that we mentioned earlier that mammography is generally not used under the age of 30. There are exceptions to every rule, as everyone knows. So there are occasions in which we'll perform mammography under age 30, but it is uncommon. This is our first take-home point from my lecture today. High-risk patients who are pregnant or breastfeeding should still get their screening mammograms. The next breast imaging study we're going to talk about is a breast MRI with contrast. This is an important topic for us to discuss because high-risk patients generally have a recommendation for mammography plus breast MRI. Remember, we spoke earlier that there are situations in extremely high-risk patients in whom they will be getting an MRI without a mammogram, but usually it's a mammogram plus an MRI. An MRI for breast cancer screening requires an IV placement because we use IV contrast. MRI uses magnetic fields, so there's no radiation. Breast MRI is recommended for screening in addition to mammography for high-risk women, except if you're young. Breast MRI is not limited by dense breast tissue. And in fact, as you can see on the right-hand side of the screen, there's a really beautiful example of a cancer that was detected in a BRCA gene mutation carrier. And that cancer could not be seen on the mammogram. Even in retrospect, the breast radiologist cannot see it on the mammogram. Breast MRIs are a very good test to find breast cancers. It's because the cancers take up the IV contrast because they typically have more blood flow than the surrounding breast tissue. And so instead of using a difference in how the cancer looks compared to the normal breast tissue, we're using a difference in how the cancer takes up the contrast that we put through your IV. This is why a breast MRI without contrast is not used for breast cancer screening. So for breast cancer screening, we need the breast MRI to have contrast administered. Contrast is not usually administered during pregnancy. It is because it is thought that the contrast can cross the placenta, and we would not wish to cause any harm to the unborn child. As a result, when it's reasonable, we'll wait until the patient is no longer pregnant. If you are lactating and you have a plan to stop lactating, if you plan to stop breastfeeding in the next couple months, then we'll usually say, then have your breast MRI done just a couple months after you stop breastfeeding. If you do not plan to stop breastfeeding soon, the MRI with contrast is perfectly okay to do when you are breastfeeding. There is no need to pump and dump the breast milk after your breast MRI with contrast unless you as the mother wishes to do so. So this is take-home point number 2. High-risk patients who should be getting screening breast MRI with contrast should plan to not receive the breast MRI during pregnancy. Why? Because an MRI done without contrast is not helpful for breast cancer screening. So if you are pregnant or if you plan to become pregnant, remember that if you are high risk, you will not likely receive a breast MRI with contrast during pregnancy. If you are breastfeeding, there is no reason you cannot get your breast MRI with contrast and your mammograms as regularly scheduled. The next thing I want to talk about is breast ultrasound. Ultrasound uses sound waves, so there's no radiation. However, ultrasound is not usually recommended for screening high-risk women. Why? MRIs are recommended for screening high-risk women in combination with mammograms. It is because breast MRIs find more cancers than mammograms or ultrasounds. And breast MRIs find more cancers when we even compared to a combination of mammography and ultrasound. This is the rationale why high-risk patients have recommendations for screening with breast MRI and mammography. If you're getting MRI and mammograms, ultrasounds do not find more cancers for screening, and this is why we do not perform MRI, mammograms, and ultrasounds in high-risk women. That being said, despite the fact that we know that ultrasounds find fewer cancers than breast MRI, we do know that ultrasounds find cancers in addition to mammograms, and you can see one on the screen on the right-hand side. That is a classic appearance of a cancer on an ultrasound. As a result, we can use breast ultrasound for screening high-risk women who cannot get a breast MRI with contrast. So if you are pregnant and you should have been getting a breast MRI because you are high risk, you can, instead of a breast MRI, get a breast ultrasound while you are pregnant. There is no risk to your unborn child or to you for getting an ultrasound plus a mammogram. It's just important for all of us to be on the same page that the ultrasound is being used because we cannot do the preferred test in high-risk women, and the preferred test is an MRI with a mammogram. Remember that breast ultrasound is not recommended by any medical professional organization as the only imaging study for screening. In my own practice, we do not offer ultrasound screening as the sole screening modality because there are no medical professional organizations that recommend screening ultrasound only. When we do screening ultrasound, we are doing it in addition to mammography. This brings me to take-home point number 3. Breast ultrasound alone is not recommended for screening. It is not recommended for screening pregnant women, and breast ultrasound alone is not recommended for screening lactating women. So let's review how we want to perform screening in women who are pregnant. Mammography or mammograms are fine while you're pregnant. Breast ultrasounds are fine when you are pregnant. The radiation dose from a mammogram is exceptionally low to the mother, and it is extremely low to the unborn child. Remember that we cannot offer contrast administration to pregnant patients. So we cannot offer a breast MRI with contrast for screening while you are pregnant. As a result, if you are pregnant and you are at high risk and you should have been getting a breast MRI with contrast, we would be left with our only option to perform mammography with breast ultrasound. I should take this opportunity to mention that this scenario is not unique to a pregnant patient. So anytime we have a patient who is at elevated risk, who should have been getting a breast MRI with contrast, and they cannot receive the MRI, maybe they have a cardiac device that's been implanted, and it is not safe for them to go into the MRI scanner. In that scenario, we would also offer mammography with ultrasound as an alternative, even though it is not the preferred screening regimen. The preferred screening regimen for women who are at high risk is a mammogram plus an MRI with contrast. And we use ultrasound as a backup plan. We also will use breast ultrasound for screening in women who are not quite at a high enough risk to warrant screening with an MRI. So there are some patients who are not quite at a high enough risk to qualify for a breast MRI with contrast for screening. And in that situation, we can also use ultrasound. There's one other time when we use ultrasound, and that is if you come in feeling a lump or bump, or your doctor feels a lump, or if we see something on a mammogram that might concern us, we might look with a focused ultrasound, but that's an ultrasound that's being used to evaluate a specific area. It's not being used to look at both breasts in their entirety. That ultrasound is not being used for screening, so it's a different indication, but it's still an ultrasound. It's just a different kind of ultrasound. This is my last slide today. While you are breastfeeding, you may have mammography, ultrasound, or an MRI with contrast. If you get your MRI with contrast, you do not need to pump or dump unless you wish to do so, okay? I am so thankful for your time today. I'm sorry I was not able to join you for questions. I had a prior engagement and needed to be traveling during the time when I would have been available for questions. But thank you for your time today.